what your cannula is telling you. One of the first frustrations every new injector experiences isn't finding the anatomy. It's simply getting the cannula in. The pilot hole has already been made with your needle, yet somehow the cannula refuses to enter. It catches. It bends. It pushes the skin instead of going through. Almost every beginner has experienced this. The reason is simple. The hole you've created isn't a tunnel. It's a tiny slit in the skin. If your cannula approaches that slit at a slightly different angle, the blunt tip simply hits the edge instead of finding the opening. Slow down. Look at the angle you created with the needle. Now introduce the cannula at exactly the same angle and in exactly the same direction. You'll be amazed how often it suddenly slides in effortlessly. Getting into the skin is often harder than navigating once you're underneath. Now imagine what lies below. Many beginners think the subcutaneous layer is a single thin plane that the cannula has to find with millimeter precision. It isn't, in most places. The subcutaneous layer is actually several millimeters thick, many times thicker than the diameter of your cannula. Your cannula might be only 0.7 millimeters wide, yet the superficial fat layer may be 5 or 10 millimeters thick. That means you have a generous working corridor. Whether you're 1 millimeter higher or 2 millimeters lower within that superficial fat, you're usually still in the same anatomical compartment, achieving the same clinical result. This is why beginners shouldn't become obsessed with finding one perfect microscopic depth. Instead, think about remaining within the correct anatomical layer. Once inside, pay attention to what your fingertips are telling you. Fat feels soft. The cannula glides, almost like moving through butter. Occasionally, you'll feel tiny interruptions, little clicks. These are usually fibrous septae or small superficial branches of retaining ligaments. They divide the fat into tiny compartments. They don't require force, just steady, controlled pressure. Often the cannula simply passes through. Then, occasionally, everything changes. The cannula stops. It feels as though someone has put their finger against the tip. That's usually a major retaining ligament. These thicker ligament trunks anchor the skin and superficial tissues to deeper fascia and bone. They're stronger, denser, almost rubber-like. Don't panic, don't force it. Experienced injectors often know exactly where these ligaments live. After hundreds or thousands of treatments, they anticipate the resistance before they reach it. Rather than becoming surprised by it, they apply gentle, deliberate pressure while maintaining the correct plane. Sometimes the cannula passes through. Sometimes they redirect slightly around it. Both approaches are perfectly reasonable depending on the anatomy and the treatment. What they don't do is jab harder and hope for the best. Now, let's talk about something equally important. What actually happens to the tissues in front of your cannula? The beauty of a blunt cannula is that it rarely cuts structures. Fat simply separates. Small superficial nerves usually glide to one side. Small veins and arteries are displaced rather than pierced. Tiny ligament branches stretch or separate. This is one reason why staying superficial makes so much sense. The superficial tissues are softer, more forgiving, and contain smaller neurovascular structures. The deeper you travel, the larger and more important the anatomy becomes. The retaining ligaments become thicker. The fascial planes become denser. The vessels become larger. The facial nerve branches become increasingly relevant. There is simply more to lose. So how do you actually stay superficial? This is one of the simplest tricks I teach. Watch the shaft of your cannula while you're advancing it. If gentle forward pressure produces a slight concave curve, where the middle of the cannula bows gently downward and the tip tents the skin. That's exactly what you want. It tells you the tip is naturally hugging the undersurface of the skin. The skin lifts slightly. You can often see the tip through the surface. You're staying superficial. If instead the cannula bends the opposite way, forming a convex bow, the tip is pointing downward. Instead of lifting the skin, it's diving into the deeper tissues, toward the deeper retaining ligaments, toward larger vessels,
Okay.
towards structures you often don't want to meet. The cannula itself is giving you feedback. Learn to watch it. One final point about injection technique. As beginners, I recommend injecting on the retrograde pass. Advance first. Inject while withdrawing. Your cannula is stable. You know exactly where you've been. It's predictable and easy to learn. With experience, many injectors become comfortable injecting during both advancement and withdrawal. They've developed enough tactile awareness to anticipate resistance, understand the anatomy beneath the skin, and adjust instantly. But that comes with experience. Master retrograde injections first. Then expand your technique later. Remember, injection anatomy isn't about memorizing arteries. It's about understanding tissue. Your fingertips become your eyes. The resistance tells you where you are. The cannula tells you whether you're superficial or deep. And eventually, after enough faces, you'll realize something remarkable. The face starts talking to you. If you found this useful, there's a good chance you know someone else who would too. Send them this video. It might make their next injection a little safer and a little better. And if you'd like more practical aesthetic education like this, subscribe. It really does help the channel grow.